be presented by Dr. Akinyemi from Howard University, and it's entitled Impact of the Affordable Care Act on Revascularization versus Amputation in Patients Presenting with Chronic Limb-Threatening Ischemia in Maryland.
Thank you everyone for this opportunity to present findings from our study. My name is Oluwasegun Akinyemi. I'm a Senior Research Fellow at the Howard University College of Medicine. Today, I will be talking on the impact of the Affordable Care Act on revascularization versus amputation in patients presenting with chronic limb-threatening ischemia in Maryland. I have no disclosures. When the Affordable Care Act was passed into law in 2010, one of the major goals of the policy was to expand Medicaid eligibility. And therefore, it is not surprising that since the implementation of the policy, there has been more than 20 million previously uninsured Americans who have since have access to affordable health care coverage. And we continue to see in the literature that in states where this policy has been implemented, there has been demonstrable expansion of healthcare access and also better outcomes. As at January 2024, 40 states in the United States has implemented this policy, with the state of North Carolina joining the list in December 2023. In Maryland, since the policy was implemented in 2014, it has significantly impacted on medical practice, and this includes the management of patients who present to the hospital on account of chronic limb-threatening ischemia. So the objective of our study was to examine the impact of the implementation of the policy on revascularization versus amputation rates among patients who present to the hospital on account of chronic limb-threatening ischemia. We analyzed data using the Maryland State Inpatient Database and compared two time periods: the pre-ACA period, which we defined as the period between 2007 to 2009, and the post-ACA period, which we defined as the period between 2018 to 2020. We utilized regression analysis and estimate odds of revascularization versus amputations among this particular group of patients. At the section of the study, there was no significant difference in baseline characteristics of the study population in the pre-ACA period compared to the post-ACA period. However, we noticed a significant drop in the population of patients presented to the hospital on account of CLTI in the post-ACA period. And this could be attributed to a change, an increase in ambulatory care management of some of these patients. As it's expected, we noticed a significant increase in the proportion of patients who were Medicaid beneficiaries who received care on account of CLTI. With this increase in the Medicaid population from 11.3% in the pre-ACA period to about 14.5% in the post-ACA period, there was a concomitant reduction in the proportion of patients who had private insurance or self-pay. We noticed a very notable finding in our study, looking at the treatment pattern of patients with CLTI in the post-ACA period. In the pre-ACA period, 56.1% of these patients actually had amputations. However, in the post-ACA period, an impressive 77.4% of these patients had limb salvage procedures, which is revascularization. We went ahead to conduct a retrospective analysis to test our finding, and we adjusted for patient baseline characteristics, we adjusted for patients having pre-existing comorbidities, We adjusted for patient lifestyle behaviors and hospital characteristics. And even after this adjustment, we found that the post-ACA period was associated with a fourfold increase in the odds of a patient undergoing a revascularization, which is a limb salvage procedure, compared to an amputation among this particular group of patients. Looking at this figure gives us a more granular look at our study. So what we did here is, you look at the blue line represents the proportion of patients in the pre-ACA period who underwent limb salvage procedures, which is revascularization, while the yellow line represents the proportion of patients who underwent limb salvage procedures, revascularization, in the post-ACA period. And as you can see, for every race, for white patients, black patients, Hispanics, Asian Pacific Islanders, Native Americans, and others, there was a significant increase in the proportion of patients receiving limb salvage procedure, receiving revascularization, compared to amputations in the post-ACA period compared to the pre-ACA period. Furthermore, we went ahead to look at how the policy impacts on adverse outcome. So we selected two adverse outcomes, which we define as the in-hospital mortality and also the experience of a prolonged hospital stay. And irrespective of the treatment modality, whether it's amputations, whether it's revascularizations, the post-ACA period was associated with a significant drop in in-hospital mortality and also prolonged extended hospital stay. Our study has some limitations. One of these limitations is the fact that we use retrospective, we use administrative database and also ICD code that can be prone to coding errors. Also, we do not assess for long-term complications and other outcomes that could go beyond the immediate post-operative period. In conclusion, in the post-ACA period, we notice a substantial increase in limb salvage procedure, revascularization, among patients who are patients with chronic limb-threatening ischemia. Also, we noticed that the procedure became safer, as evidenced by a significant drop in adverse outcome. And more interestingly, this trend was found among all race and ethnicity. This is our team. We'll be happy to answer your questions. Thank you.
Maryland to the microphone to discuss this paper.
Good afternoon. Thank you to the Southeastern Circuit Congress and to the authors for the privilege of discussing this paper, and thank you to the authors for getting it to me in a timely fashion. I really appreciate that. I'm KJ Nagersha from the University of Maryland. I'm a vascular surgeon. So the authors here, they present a study looking at the population of patients in the state of Maryland who had critical limb-threatening ischemia who either underwent revascularization or major lower extremity amputation. They performed this analysis in relation to a significant change in practice patterns as related to the implementation of the Affordable Care Act. Prior to the Affordable Care Act, it looked like patients with CLTI were more likely to receive a major limb amputation, and following, it looks like they were more likely to receive a revascularization procedure. Though these are interesting temporal findings, I do have several questions and comments for you authors. Number one, it's well established that patients with PAD, peripheral artery disease, have a higher risk of major limb amputation than the general population. PAD exists on a spectrum from asymptomatic all the way through to major tissue loss. CLTI also exists on a spectrum from ischemic rest pain all the way to major tissue loss. They also have a higher rate of major amputation. You have major tissue loss. Did you stratify patients with CLTI based on the type of CLTI they had? There are different ICD-10 codes for each different type of CLTI, which would be able to be found in an administrative database. Second question. Maryland has a very unique reimbursement model called global budget revenue, which is different from the rest of the country. May not be something you're familiar with, but essentially it's an all-payer model which creates a capitated system for the hospitals in the state of Maryland, right? So there's a huge financial incentive to move care outside the hospital. which has led to a boom in outpatient endovascular suites being created throughout the state, and more endovascular revascularization procedures being performed outside of hospitals. So many of these patients with CLTI have many more procedures now than they did prior to 2014 when GDR went into effect. That falls into your timetable here for pre-ACA, post-ACA. Could that be a confounding factor, and how do you account for that in your findings? My final question relates to the advances in vascular care. In the last 5 to 10 years, vascular care has advanced dramatically in both open and endovascular techniques. Patients that were considered no option critical limb ischemia 5 years ago now have options. We have things like deep venous arterialization, injections of lymphatic or proliferative lymphocytes to help with CLTI. Could it be that these advances in techniques and treatments have decreased the rates of major limb amputation in this population as opposed to expansion of insurance policies? Thank you very much for the opportunity.
Thank you, Dr. Pejan, for reviewing our manuscript and for your questions. For the first question, actually what we did was we did not stratify these patients, the CLTI patient. What we just did was to look at the ICD codes for CLTI, and that is what we used. So we didn't actually stratify. And secondly, talking about, we actually noticed the shift in ambulatory care. We noticed that a large proportion of our patients, when we discovered that there was a slight drop in the number of patients, we also went and tried this particular analysis using the Maryland ambulatory data set. And like we said, we noticed that there was a lot of patients in the Maryland ambulatory data set that kind of offset the reduction that we noticed in the state inpatient data set. But even looking at those patients who were in the ambulatory data set, this larger proportion of these patients still had the limb salvage procedures. And thirdly, like you said, it is possible that this could be as a result of advancing technique, but it is also possible that because these patients now, because there is expansion of access, that these patients are likely to present to the hospital in earlier stages of CLTI, then they are more likely to be candidate for revascularization rather than amputations. So one of our plans for a future study is to do a study where we had a difference analysis, where we compare Maryland with another state where there is no, in that other state where states that is yet to implement this policy. So comparing those changes with the two states, we will be able to really say categorically whether this is as a result of the implementation of the policy or maybe that is not the case. Thank you.
Dr. Akinyemi, thank you very much for a fine presentation. Also congratulate you on your paper being a gold medal finalist. And then on behalf of the leadership of the Southeastern and the program committee, I'd like to present you with this plaque recognizing your achievement.